An ECG, electrocardiogram showing ventricular extrasystoles, also known as premature ventricular contractions, PVCs, presents with several distinctive features. Characteristics of ventricular extrasystoles on ECG. 1. Wide and bizarre QRS complexes. PVCs originate from the ventricles and therefore do not follow the normal conduction pathway through the AV node and his Purkinje system. This results in a QRS complex that is usually wider than 120 milliseconds and has an abnormal shape. 2. Absence of preceding P wave. Since the impulse originates in the ventricles, it is not preceded by atrial depolarization. Thus, a P wave is absent before the PVC. 3. Compensatory pause. Most PVCs are followed by a compensatory pause. This is because the PVC typically occurs earlier than the next expected sinus beat, and the sinus node continues to fire on schedule, resulting in what appears to be a pause until the next sinus beat. However, the interval from the sinus beat before the PVC to the sinus beat after the PVC is typically twice the normal sinus cycle length, not truly a pause. 4. Discordant ST segment and T wave changes. The ST segment and T wave are usually in the opposite direction, discordant to the major deflection of the QRS complex due to the altered depolarization and repolarization sequence. 5. QRS morphology. The morphology of the QRS complex of a PVC can vary depending on the origin of the PVC within the ventricles. Common patterns include a right bundle branch block-like pattern for PVCs originating in the left ventricle, and a left bundle branch block-like pattern for PVCs originating in the right ventricle. 6. Frequency and pattern. PVCs can occur as isolated beats in pairs, couplets, or in runs of 3 or more, ventricular tachycardia if sustained. They can be uniform, monomorphic, or vary in appearance, polymorphic. Clinical significance. Frequency. Occasional PVCs are common in healthy individuals and might not have clinical significance. However, frequent PVCs, especially in certain patterns or in the context of underlying heart disease, may require further evaluation and management. Underlying conditions. PVCs can be associated with electrolyte imbalances, hypoxia, myocardial ischemia, cardiomyopathies, and the use of certain substances like caffeine, alcohol, or medications. Symptoms. Some individuals may be asymptomatic, while others may report palpitations, skip beats, or an awareness of the heart's activity. When interpreting an ECG with ventricular extrasystoles, it's crucial to evaluate the overall context, including the patient's clinical status, symptoms, and any underlying cardiovascular conditions, to determine the significance and need for further investigation or treatment. Clinical case, ventricular extrasystoles. Patient information, age, 45 years, sex, male, occupation, software developer. Presenting complaint, the patient presents to the clinic with complaints of palpitations and intermittent sensations of skipped heartbeats over the past month. These episodes occur mostly during periods of rest or in the evening. Medical history, hypertension controlled with lisinopril. No history of coronary artery disease, diabetes, or significant family history of cardiac disease. Smoker, 10 cigarettes a day for the past 20 years. Social history, reports high stress at work, consumes 2 to 3 cups of coffee daily, occasionally drinks alcohol but denies recent excessive use. Physical examination, general, the patient appears well nourished and in no acute distress. Vitals, target 135 to 85 millimeter Hergrams, HR 78 BPM regular, temp 98.6 degrees Fahrenheit, RR 14 min. Cardiovascular regular rhythm with intermittent irregular beats noted, no murmurs, rubs, or gallops. Respiratory, abdominal, neurological exams, unremarkable. Initial investigations, ECG. shows normal sinus rhythm with occasional wide and bizarre QRS complexes not preceded by P waves, consistent with ventricular extrasystoles. A compensatory pause follows each extrasystole. Further workup, 24-hour Holter monitor reveals frequent monomorphic ventricular extrasystoles with a burden of 5% of total heartbeats. Echocardiogram, normal left ventricular size and function, no valvular abnormalities, ejection fraction estimated at 60%. Management, lifestyle modifications. The patient is advised to reduce caffeine intake, quit smoking, and implement stress management techniques. Medication review. The current antihypertensive regimen is deemed appropriate, with no changes made. Follow-up. The patient is scheduled for a follow-up in 6 months or sooner if symptoms worsen. Given the benign nature of the findings and the absence of structural heart disease, no immediate pharmacological treatment for the ventricular extrasystoles is initiated. Outcome. At the 6-month follow-up, the patient reports a significant reduction in palpitations after reducing caffeine intake and starting a regular exercise program. A repeat ECG and Holter monitor show a decreased burden of ventricular extrasystoles. Discussion. This case illustrates a common presentation of ventricular extrasystoles in an otherwise healthy individual with controlled hypertension. The primary approach focused on lifestyle modifications given the absence of underlying structural heart disease and the benign nature of the extrasystoles. This case underscores the importance of a thorough evaluation to rule out structural heart disease in patients presenting with ventricular extrasystoles and highlights the potential impact of lifestyle factors on cardiac arrhythmias. Oral exam questions and answers on ventricular extrasystoles. Question 1. Q. How can you differentiate ventricular extrasystoles from supraventricular extrasystoles on an ECG? A. Ventricular extrasystoles, VES, are characterized by wide and bizarre QRS complexes with 120 MSICs, without a preceding P wave due to the ectopic beat originating in the ventricles and bypassing the normal conduction pathway. Supraventricular extrasystoles, SVES, on the other hand, originate above the ventricles and typically have a normal or slightly widened QRS complex, often preceded by an abnormal P wave if originating from the atria. The presence of a compensatory pause is more common in VES. Question 2. Q. What are the potential clinical implications of frequent ventricular extrasystoles in a patient with known heart disease? A. In patients with underlying heart disease, frequent ventricular extrasystoles can indicate increased risk for more serious arrhythmias, such as ventricular tachycardia or ventricular fibrillation, especially if they are polymorphic, occur in pairs, couplets, or as runs of non-sustained ventricular tachycardia. They may also contribute to worsening heart failure by disrupting the normal synchrony of cardiac contractions, leading to decreased cardiac output and efficiency. What lifestyle modifications would you recommend to a patient with benign ventricular extrasystoles? A. For patients with benign ventricular extrasystoles, especially those without underlying heart disease, lifestyle modifications can include reducing or eliminating caffeine and alcohol intake, quitting smoking, managing stress through relaxation techniques or exercise, and ensuring adequate hydration and sleep. These changes can help reduce the frequency of ventricular extrasystoles and alleviate associated symptoms. Question 4. Q. In what clinical scenario would you consider pharmacological treatment for ventricular extrasystoles, and what options are available? Pharmacological treatment for ventricular extrasystoles may be considered in patients who are symptomatic, frequent palpitations, discomfort, those with heart disease in whom VES might pose a higher risk, or when the extrasystoles significantly compromise cardiac function. Treatment options can include beta blockers as first-line therapy to reduce adrenergic stimulation. In select cases, antiarrhythmic drugs like Class I agents, e.g. flecainide, or Class III agents, e.g. amiodarone, may be used under careful monitoring due to their potential proarrhythmic effects. Question 5. Describe the significance of a compensatory pause following a ventricular extrasystole. A. A compensatory pause following a ventricular extrasystole occurs because the premature beat resets the sinus node timing, leading to a longer interval before the next normal beat occurs. This pause is not truly double the normal RR interval, as the sinus node can use to fire on schedule, but the premature beat causes the next sinus beat to fall within the refractory period of the ventricles and not be conducted. The compensatory pause can contribute to the sensation of palpitations or skipped beats, often reported by patients. These questions delve into key aspects of understanding, diagnosing, and managing ventricular extrasystoles, reflecting the comprehensive knowledge required in clinical practice. Premature ventricular complexes, PVCs. Overview. Characteristic symptoms and pathophysiology. PVCs arise from ectopic foci within the ventricles, leading to premature and abnormal heartbeats. The reduced diastolic filling time associated with PVCs can decrease stroke volume, potentially causing symptoms like palpitations or dizziness in some individuals. B. Clinical presentation and diagnosis. Symptoms, often asymptomatic, when present, may include palpitations, dizziness, or a sensation of skipped heartbeats. ECG findings, characterized by wide 120 milliseconds bizarre QRS complexes without preceding P waves and followed by a compensatory pause. PVCs can be monomorphic, identical in shape, or polymorphic, varying shapes. C. Treatment, general management, address underlying causes if present, such as electrolyte imbalances or ischemic heart disease. Lifestyle modifications like reducing caffeine and alcohol intake can be helpful. Medication, antiarrhythmic drugs such as beta blockers, e.g. bisoprolol, metoprolol, or non-dihydropyridine calcium channel blockers, e.g. diltiazem, verapamil, are first-line treatments for symptomatic PVCs. Catheter ablation, considered for symptomatic patients who do not respond to medication or prefer a non-pharmacological approach. D. Prognosis and complications. Most individuals with PVCs, especially those without underlying heart disease, have a benign prognosis. Complications can include PVC-induced cardiomyopathy and, rarely, arrhythmias like torsades de pointes or ventricular fibrillation, especially with high PVC burdens or specific patterns, e.g. R-on-T phenomenon. High yield points. PVCs are common and can be found in healthy individuals, with prevalence increasing with age. Frequent or symptomatic PVCs, especially in the context of heart disease, warrant further evaluation and potential treatment to prevent complications. The management strategy for PVCs is tailored to the patient's symptomatology, underlying etiology, and the presence of any associated cardiomyopathy. Differential diagnosis considerations. Supraventricular tachycardia, SVT with aberrancy, can resemble PVCs on ECG but typically have a preceding P wave. Ventricular tachycardia, VT, a run of 3 or more consecutive PVCs at a rate of more than 100 beats per minute. Atrial fibrillation with aberrant conduction. Irregular rhythm with varying QRS morphology might mimic polymorphic PVCs. Clinical case, premature ventricular complexes, PVCs. Patient information, age 58 years, sex, male, occupation, high school teacher. Presenting complaint, the patient reports experiencing palpitations and intermittent sensations of heart fluttering for several months. These episodes occur randomly, sometimes at rest and occasionally during physical activity. Medical history, hypertension, controlled with hydrochlorothiazide, no known coronary artery disease or diabetes. Father had a history of heart problems, details unclear. Social history, reports moderate stress at work, consumes 1 to 2 cups of coffee daily, denies tobacco or illicit drug use, occasionally drinks alcohol, mainly on weekends. Physical examination, general, patient is alert, oriented, and appears in no acute distress. Vitals, BP 138, 82 millimeter cry, HR 76 BPM, regular, temp 98.2 degrees, RR 14 min. Cardiovascular, regular rhythm with occasional irregular beats noted, no murmurs, rubs, or gallops. Respiratory, clear to auscultation bilaterally. Extremities, no edema, pulses intact. Initial investigations, ECG, reveals normal sinus rhythm with frequent monomorphic PVCs, no significant ST or T wave changes noted. Further diagnostic workup, 24-hour Holter monitor, confirms the presence of frequent monomorphic PVCs, accounting for 6% of total heartbeats, with a couple of couplets but no runs of ventricular tachycardia. Echocardiogram shows normal left ventricular size and function, with an ejection fraction of 62%, no valvular abnormalities or signs of pulmonary hypertension. Blood tests. Basic metabolic panel within normal limits, including potassium and magnesium levels. Normal thyroid function tests. Management. The patient is counseled on lifestyle modifications, including reducing caffeine intake and managing stress through regular exercise and relaxation techniques. Given the patient's symptoms and the frequency of PVCs, a trial of beta blocker therapy, metoprolol, is initiated. The patient is advised to monitor his symptoms and follow up in 3 months or sooner if symptoms worsen. Outcome: at the 3-month follow-up, the patient reports a significant decrease in palpitations and an improved sense of well-being. Repeat Holter monitoring shows a reduction in PVC burden to 2% of total heartbeats. The patient tolerates the beta blocker therapy well, with no adverse effects reported. Discussion. This case highlights a common presentation of symptomatic PVCs in a patient without significant structural heart disease. The management approach underscores the importance of lifestyle modifications and the selective use of beta blocker therapy in symptomatic individuals, leading to an improvement in symptoms and quality of life. The case also illustrates the utility of non-invasive cardiac monitoring and imaging in assessing the burden of PVCs and ruling out underlying structural abnormalities. Oral exam questions and answers on premature ventricular complexes, PVCs. Question 1. Q. What are the typical ECG findings associated with PVCs? A. PVCs on an ECG are characterized by wide but 120 milliseconds bizarre-looking QRS complexes that are not preceded by P waves, indicating that the impulse originates from the ventricles. There is usually a compensatory pause following the PVC, and the T wave is often in the opposite direction of the QRS complex. Question 2. How do you differentiate between monomorphic and polymorphic PVCs, and what is the clinical significance of each? A. Monomorphic PVCs have the same shape and originate from a single ectopic focus within the ventricles, suggesting a localized irritability. Polymorphic PVCs vary in shape and originate from multiple ectopic foci, indicating a more diffuse ventricular irritability. Monomorphic PVCs are generally less concerning, while polymorphic PVCs, especially in the setting of acute myocardial infarction, can be a precursor to more dangerous arrhythmias like torsades de pointes or ventricular fibrillation. Question 3. Q. What are the common causes or triggers for PVCs? Common causes or triggers for PVCs include electrolyte imbalances, especially hypokalemia and hypomagnesemia, ischemic heart disease, myocarditis, cardiomyopathy, stimulants such as caffeine and nicotine, alcohol, stress, and certain medications like digoxin and sympathomimetics. Question 4. Q. When is treatment indicated for PVCs, and what are the treatment options? A. Treatment for PVCs is typically reserved for symptomatic patients or those with a high burden of PVCs that may contribute to cardiomyopathy. Treatment options include lifestyle modifications, e.g. reducing caffeine and alcohol intake, stress management, beta blockers, and in refractory cases, antiarrhythmic medications or catheter ablation to target the ectopic focus. Question 5. Q. What is the R-on-T phenomenon and why is it clinically significant? The R-on-T phenomenon occurs when a PVC falls on the T wave of the preceding beat, specifically during the vulnerable period of ventricular repolarization. This timing increases the risk of triggering a ventricular tachyarrhythmia, such as torsades de pointes or ventricular fibrillation, especially in patients with underlying heart disease or electrolyte imbalances, leading to a potentially life-threatening situation. These questions encompass key aspects of understanding, diagnosing, and managing PVCs, reflecting the comprehensive knowledge required in clinical practice.